Child abuse is a difficult topic, and I know this can be hard for some, so that is my disclaimer. So the problem of child abuse, we know that 2.9 million cases of child abuse are reported each year in the United States. Now keep in mind that that is just the cases that are reported, so it's likely a far bigger problem than what is actually documented. We also know that there are 2,000 to 5,000 child abuse fatalities each year, and that 1 in 5 families has a problem with abuse, and that may be physical abuse or psychological abuse. 25.2 abuse cases occur per 1,000 children, so that does show you how prevalent it is. If we're looking at the different types of abuses and neglect in the United States alone, we see that 4% are emotional abuse, and of course you're going to see emotional trauma experienced by all children who have undergone some type of physical abuse or neglect. Emotional abuse, the 4%, is addressing just those children who profess to experience emotional abuse in the absence of sexual, physical, or neglect. 1/3 of all reports are substantiated, so it is more common to be reported. As healthcare providers, we're required to support suspected cases of child abuse or neglect. So we don't have to have 100% proof, but we do need to make sure that we have a valid reason for contacting either law enforcement or our social services agency. So abuse is defined as mental, emotional, physical, or sexual injury to a child, or a failure to prevent such injury to children. What is neglect? This is a failure to provide a child with food, clothing, shelter, or medical care, or perhaps leaving a child in situations where they may be at risk of harm. Our job in healthcare is to recognize those children that we suspect of being at high risk. We are charged with the recognition of suspicious injuries, and we're required to perform physical evaluations that require obtaining maybe physical evidence or evidence in the form of maybe photographs or documentation on diagrams. We need to make sure, though, that we consider all of the possibilities before we report any suspected abuse. So it's very critical that we remain objective in all assessments. On top of reporting or recognizing, it is so important for us to advocate for children and to formulate impressions that are based on facts. So our impressions, or formulating impressions, must take into consideration the child's age and developmental level, the reported history of the event, locations of injury, and I show this picture here of a foot because injuries such as burns to bottom of the feet can be more concerning than, say, burns to hands. Type and severity of the injury, what are the caregiver's explanations, and the time frame from the actual injury to seeking treatment. So our role in formulating impressions can be pretty basic. We look at injuries and we say, are these consistent with maybe non-accidental injury? And if so, is there evidence of intent? Or are these injuries clearly consistent with something that is obviously an accidental injury? We need to be very careful of making knee-jerk reactions when we look objectively to consider all the possibilities. It's very important for us not to get swept away by emotions, and this is easy to do when it involves children. So before you make the call to CPS or law enforcement, you need to ask, what is it that makes me concerned about this particular child's presentation? So these are some very good questions to ask yourself. Is it the history that you find concerning? Is there, say, a delay in seeking treatment? Are there multiple injuries in various stages of healing? Are there any concerning patterns? What is that child's overall appearance, and is their behavior or demeanor a concern? And be very careful about your documentation. So remember, child abuse is a legal definition. Your role is to be part of that multidisciplinary team and recognize that you are a part of the puzzle in the investigation. You're going to be working with folks like law enforcement, emergency medical services, other medical personnel, maybe forensic nurse examiners if your facility has a program, social services, the Commonwealth attorney or prosecuting attorneys, victim witness programs, child advocacy centers if one is available in your community. So this is some of the requirements for reporting suspected child abuse. In Virginia, it's Child Protective Services. In the state of West Virginia, it's the Department of Health and Human Resources. So social services may be called something different depending on your location. If the alleged victim is under the age of 18 at the time of the report, then this is mandatory for you to contact either law enforcement or child protection. If the abuser is in a caretaker role, and that means anyone from teachers to bus drivers to babysitters to parents. So it depends on what the role is of the person. If the abuse or neglect meets the definition of abuse or neglect as defined by law enforcement regulations and policy, the Virginia Department of Social Services local agency has jurisdictions to respond to reports of any types of suspected child abuse dependent upon where the abuse or neglect has occurred. So it's where the child resides. So, and the same is true for West Virginia and other states. But, again, clarify that depending on where it is that you work. These are some of the behavioral indicators which might arouse suspicion that a child may be at high risk or maybe has actually suffered from some type of abuse or neglect. If a family member or a parent or the caregiver is a poor historian about the child, if they are evasive or contradicting themselves, if they show a lot of irritation during questioning, a lack of concern, or maybe they're overly concerned, if they're disappearing, or maybe they've even abandoned their child, drop them off and then leave the hospital or whatever setting. If they are distant from the child, or if they're rather preoccupied with self, or they minimize the severity of the injury. So these are all indicators. It's more of a combination of these types of indicators, more so than just one alone. More concerning behaviors include a delay in seeking treatment. In my experience, this has been a very big concern and a really high indicator of abuse, that delay in seeking treatment. If there are attempts to conceal injury, if they offer alternative explanations such as they just bruise easily, or they're just so clumsy, or they were just roughhousing, if the caretaker is blaming someone else or prompting the child, or if they're showing threatening behaviors. Behavioral clues from children, maybe not quite as indicative, especially if you're in a clinical setting where it's frightening for children. So, but again, it's a combination of factors. Is that child crying hopelessly under treatment and examination, or is there just a total lack of crying, just a sense of apathy? If they don't look to parents or really anyone for comfort, if they're really wary of physical contact, if they appear apathetic or hypervigilant, such as someone who maybe have a history of trauma, so they are very distrusting of the world around them. If their affect is bizarre, maybe flat, maybe blunted, if they have a high pain threshold, we are looking at a combination of these and not one specific thing out of this list can or would be completely suspicious of child abuse, but it's the combination. If a child presents and there's very poor hygiene, if they're not appropriately dressed, if they're malnourished, dental issues, lacking in immunizations or medical care, if they're left unattended, or you notice that the children are caring for other siblings, this may be more indicative of a child's need or a family's need for resources due to financial difficulties or lack of access to services. Maybe there is a lack of resources. So, this might not be an indicative of child abuse, but simply a lack of resources. So getting into the details about injuries, we know most accidental injuries tend to happen over bony prominences. The skin there's just not a lot of adipose tissue over top of sharp bones, such as like your elbows or your shins or your knees. If children have frontal injuries, this is less concerning for non-accidental trauma because the body instinctively twists and turns to fall forward, kind of like a cat that falls on its feet. So non-accidental injuries are typically the types of injuries that you see over padded areas. If there's patterned injuries, for instance, maybe a hairbrush or a handprint is an example of a patterned injury. If there are multiple lesions in various stages of healing, especially if they include those padded areas in these posterior locations like on the back, on the belly is a very concerning location. So accidental injuries on poorly padded areas like over bony prominences, if there are non-specific patterns, if there are few lesions and there's no delay in seeking treatment, and of course if the history matches what you're actually seeing. There are several differential diagnoses that need to be ruled out before you make those contacts with social services or law enforcement. Children need to have a workup, possibly for bleeding disorders, maybe looking at whether or not what you're seeing is a birth type of marks, like Mongolian spots. Maybe there's a condition that's henoch-scullion purpura. There might be cultural types of practices that look like abuse, like corn rubbing or cupping, or certain developmental disorders. This is an image of henoch-scullion purpura, and this is a hyper sensitivity like vasculitis. It's an inflammatory response within blood vessels, and it's caused by an abnormal response of the immune system. So it's not something that you're going to see very often, but when you do, it looks like it could be inflicted trauma, but differential diagnosis will tell you otherwise. So Mongolian spots, some darker skinned babies sometimes are born with these types of birth spots. So it looks like bruising, but it's actually been there since birth, and it's certainly not a finding that's concerning for trauma. In fact, it would be really important for parents to have like a laminated card signed by a physician or healthcare provider that says this child was born with these types of birthmarks, and again called Mongolian spots. This is a cultural practice called coining or cupping, where cups are put in alcohol, then they're lit on fire. Of course, the fire is blown out, and they're cooled a little bit, put against the skin, and it creates a suction. And this is thought to kind of rid the body of toxins. So if you see these types of circular, images, make sure you ask people what caused them and what was that practice, to determine if it is some type of a healing practice. Patterned injuries. This is a classic patterned injury, and it was caused by a belt loop. So the object impacted the tissue and left an impression on the skin. So a pattern of injury might encompass patterned injuries, but when I say a pattern of injury, we're talking more about that combination or distribution of external or internal injuries, and it suggests a causative mechanism or a sequence of events that indicate the possible inflictions of wounds over a period of time. So moving on to abuse types of fractures. If fractures are found and they are consistent or thought to be the result of inflicted trauma, they are often not isolated to one particular area. So if a child is really young, less than a toddler's age, they maybe should have a skeletal survey to look at all possible healed fractures where no attention for treatment was sought. So skull fractures, fifth most common. The most common fracture is rib fractures, and so these can be easily missed. It's children with extremity fractures you're going to see present to clinical settings more often because it can be more obvious. And since rib fractures are the most common, you can see this mechanism of injury here, so the squeezing of the chest. And these might be in combination with rotational force injuries such as shaken baby. So findings that suggest abuse: multiple fractures, especially fractures in different stages of healing. Fractures that are not adequately explained, maybe hidden fractures that are found on skeletal survey. Fractures in an infant, of course, are very concerning, or there's other associated injuries. Those are all concerns. So non-abusive causes of fractures you might see in birth trauma, possibly during birth, a clavicle, humerus, maybe skull or rib fractures from a difficult vaginal delivery. There may be a condition called osteogenesis imperfecta. This is a rare condition and about 1 in 100,000. So, but there is a small percentage of children born with osteogenesis imperfecta that will not show up with positive testing. So that makes a small percentage of those children who have OI concerning. Maybe prematurity, neuromuscular defects, a decreased or absent pain perception, and there is a very rare condition where a child does not experience any pain sensation. So there can be a lot of non-accidental injuries, or just injuries that occur because the child has no sensation. They might even have been gnawing at their fingers and cause really significant trauma to their entire body because they have no sensation of pain. Remember, pain is a protective mechanism. It tells us to either stop whatever we're doing to take care of the wound. It is protective. Head trauma presents as maybe trauma to the scalp, may be combined with spinal cord injuries, maybe skull fractures. Then there are intracranial injuries that can be the result of a direct impact, maybe suffocation, rotational force injuries such as shaken baby, maybe penetrating trauma as well. And these are the most common causes of death from child abuse. That's head trauma. So abusive or inflicted head trauma, we've heard of shaken baby. This is more accurately defined or described as rotational force injuries. With rotational force injuries, you may see subdural hematomas and retinal hemorrhages or subarachnoid hemorrhages. And children or babies, young babies, of course, infants, will present maybe with an inability to lift their head. They have a decreased level of consciousness, may have nausea, vomiting, present with seizures, non-reactive pupils or sluggish reactive pupils, maybe some petechiae. Petechiae are ruptured capillaries, and you can see that on the skin as reddened spots. So one of the reasons why rotational force injuries are so easy to inflict on these babies is babies have these great big heads. Their brain is very poorly myelinated, and it's surrounded by these larger subarachnoid spaces than what we see with the brains in older children and adults. So their brains are quite vulnerable. If the history is provided that this child had an accidental fall, it's important to know that accidental cranial impact, it is the most frequent explanation given by caretakers, but ground level falls are really not often so severe that they cause such a significant fatal head injury. So that's an important thing to keep in mind. Retinal hemorrhages and head injuries with infants is one of the diagnostic features associated with rotational force injuries. They are very unusual after an accidental head injury. And it's important to know that CPR rarely causes these types of small hemorrhages. Other conditions may cause retinal hemorrhages, but abuse to the head is the most likely cause. Burn injuries are the most common of abusive injury. Immersion scalds of burn injuries are the most frequent types. And with immersion scalds, what you will see is more patterns of injury or pattern typed injuries. You may see symmetrical burns of both feet, lots of areas of sparing, maybe symmetrical burns of both hands or burns of lower legs and perineum. So here's another image of some patterned injuries. This could have, it's not our responsibility to say exactly what the implement was. So this would be described as an oval type reddened area, but what looks or appears to have happened here is that some type of oval shaped object impacted the tissue, and the blood vessels or blood rapidly dispersed to the sides, and this is why you see this pattern of redness. So the actual area of impact is in the center, with blood rapidly dispersed to the sides, which causes this cylindrical pattern. Heavily padded areas, they require a pretty significant amount of force to inflict this type of trauma. And again, it's not our place to say exactly what the object was, but what we can say is it has this shape Object impacted the tissue exceeded its ability to stretch, blood was rapidly dispersed to the side, and you see this centralized area of clearing with linear patterns of bruising. This is indeed a patterned injury which suggests non-accidental trauma. Internal injuries can be missed. So these, though, can be quite fatal, of course, because you can see liver and spleen lacerations. There may be duodenal hematomas or pancreatic lacerations. So any time you see bruising to a child's abdomen, you really do have to make sure that you have further evaluation and examination. So I know this is a brief presentation, and I hope that you all will gain from this a better understanding of the types of injuries that are concerning for child abuse or non-accidental trauma, and that you will know when to report, and also before you report, rule out those differential diagnoses and be able to articulate exactly why you're concerned enough to contact and report this particular incident. Thank you.